Let's go ahead and get started. Welcome everybody to a very special breakfast with WACh. I am Patty Pavlinac. I am one of the faculty directors of Global WACh, a center devoted to research, training, and service for children, adolescents, and women. This is a speaker series devoted to highlighting various research that the Global WACh, UW, and partner teams do. And I'm just going to briefly introduce the study that the Rising Star awardees who will be presenting to you today, the study that their research is nested in. So just a little background on this study and the reason we're doing this study. We're focused on Shigella, which is an enteric bacteria responsible for close to 60,000 deaths in children per year. It's also a pathogen highly associated with linear growth faltering and stunting, decreased vaccine efficacy, and lifelong morbidity. And there are several promising Shigella vaccines in the pipeline. So this study is committed to kind of informing the Shigella vaccine pipeline, collecting necessary epidemiologic data, and kind of readying clinical trial sites for this eventual licensure vaccine trial. This is the Enterics for Global Health study. Like I mentioned, our goals are to gather key data that will inform eventual Shigella vaccine efficacy trials and to ready and standardize the procedures around estimating Shigella incidence and confirming microbiologically. The Enterics for Global Health studies conducted in 7 countries around the world, corresponding to places where the burden of Shigella diarrhea in young children is highest. And we are a multi-institution, multi-country study. We have a very much shared governance structure between scientists and administrators and coordinators from around the world, including our 7 sites. Here at the University of Washington, we play a coordinating role in this study. And then there's really important sub-studies nested in this EFGH study, which are a few of which you're going to hear about today. This is from the Rising Star awardees who are leveraging this consortium, leveraging the data, the samples that we have, and addressing really important questions that are dealing with pediatric, enteric, and diarrheal diseases. So with that, I'm going to hand it over to Kirk to Cal.
Thank you, Patty. Hi, everybody. My name's Kirk. I am one of the junior faculty at Global WACh, and I have been running the Rising Stars program in collaboration with Patty and with Irene and Jaguna as well. So the Rising Stars program at its core is a seed funding opportunity. The 3 awards that we're going to hear from today were funded by the Gates Foundation. So we're really, really grateful for the money that Gates has put forwards for this work. But we were keen to kind of do more than just give money away. So we also, within this program, have a kind of regular calendaring of mentorship and peer mentorship meetings. We were able to extend non-residential affiliate scientist positions to the Rising Stars, which is a great little CV builder, but also provides access to some of the resources that we're very lucky to have at the University of Washington that other institutions around the world don't have access to. And then most importantly for today, we're doing invited virtual lectures for all the Rising Star awardees, 3 of whom we'll hear from today. And the idea here is that, again, this is a hopefully relatively prestigious opportunity that can be included on people's CVs. It's good for our community here at the University of Washington to hear from people all over the world. And also, hopefully, it'll create some networking opportunities. So if there are people online or in the community who'd like to contact any of these rising stars and learn more about their work, feel free to reach out to me or to the EFGH team here at the university, and we'll be happy to connect you. So we have three wonderful speakers today, and I think they collectively do a great job of kind of illustrating what the Rising Stars program is about. So first of all, we're here from Taufiqul, who is joining us from Bangladesh, and if you do the time zone conversions, it's very late at night for him. So thank you so much, Taufiqul, for joining. Taufiqul comes from a medical background. He was a physician and has been working a lot on research studies over the last few years and is currently pursuing his PhD. We have Billy joining us from Kenya. Billy comes from a data science, data management background and is part of KEMRI. And again, Billy is pursuing his PhD. And finally, Maribel is joining us from Peru and has been working in research and leading research studies there for many years, and also is pursuing a PhD. So you can kind of see we have a really diverse mixture of people from all different backgrounds involved in research and trying to pursue their career and pathway towards independence. So I think what we're going to do is I'll hand it over to Taufiqul now. We will have a couple of minutes just for clarifying questions between presentations. So if there's something that you really felt you didn't quite understand in the presentation, we could take a quick question on that clarification, but then at the end, hopefully we'll have time for a kind of broader panel discussion. Okay, I won't delay any further. Taufiqul, do you want to share your slides and kick us off?
Yeah. Can you see my slide?
Yes, that looks perfect.
Thank you all. Good morning and good evening from Dhaka. I'm going to present about the proportion of secondary Shigella transmission and predisposing factors for developing Shigella infection among household contacts in the EFGH catchment area in Dhaka, Bangladesh. So before going to my detailed study, I would like to share some background. Shigellosis is an acute fecal orally transmitted intestinal infection caused by gram-negative bacteria belonging to Shigella species. Around 2.1 million deaths occur globally due to Shigella attributable diarrhea. Shigellosis is responsible for an estimated 60,000 deaths each year in under 5 children, as Patty mentioned in her first slide. This enteric bacterium is also associated with linear growth faltering and stunting. In low and middle income countries like Bangladesh, nearly 1/3 of children experience at least one episode of Shigella attributable diarrhea during their first 2 years of life. The incidence rate of shigellosis has been reported as 4.6 per 100 person years of children under 5 years of age in Dhaka, Bangladesh, from studies carried out in early 2000. Previous household contact studies conducted in endemic settings which shows that family member of shigellosis patients were at risk for developing Shigella infections. But very little evidence is available on the factors associated with this secondary transmission. And here we define household as all individuals living in the same domicile and sharing food from the same kitchen. And the household contacts were individuals of all ages who permanently resided in the same household of the index cases and were present for at least 7 days of the last 14 days. And my objectives of the study were include to evaluate the proportion of secondary Shigella transmission among the household contacts of the culture confirmed Shigella positive index cases, and also to determine the the factors associated with secondary transmission of Shigella among the household contacts. And we have followed the cohort design for this study, and our sample size was 196 household contact, considering 5% precision, 95% confidence interval, and with assuming 12% prevalence of secondary transmission and also 20% attrition rate. And here we defined the index case as the culture confirmed Shigella positive patients enrolled in the EFGH study and which was isolated from a rectal swab or a stool specimen. We invited all household members of index cases to come to our EFGH field office on day 7. We have some inclusion criteria which include the informed consenting process, the individual of all ages who permanently reside in the same household and also living in the same domicile and sharing food from the same kitchen for at least 7 days of last 14 days, and also culture confirmed Shigella infection in a household contact developed after 1 day of enrollment of index case. And we exclude those participants who were not willing to participate in the study. And informed consent was taken from the participant if age more than 18 years and their legal guardians if their age is 0 to 10 years. And we also collect assent from the children 11 to 16 years, 17 years of age. And we visited the household of the index cases on day 6 after enrollment and provided stool containers to collect stool specimen from all household members on day 7. And requested them to take the container to the field office on day 7. In addition, we asked them to come to our field office if any household member developed any acute watery diarrhea within 7 days of the index case enrollment. We called them and visited their household to ensure the collection of the stool specimen on day 7. If any household member came to EFGH health facilities with diarrhea within 7 days, we collected a stool specimen at that time and not again on day 7. If a symptomatic contact's first day of illness was less than or equal to 1 day after the enrollment of the index case, the contact was considered as co-primary infection and we excluded them from the study. And stool specimens were collected from all enrolled participants and transported to the icddr laboratory for testing by microbiological culture. Stool swab was prepared and placed dry in a transport tube for qPCR. Information on demographic, clinical, socio-economic, and exposure history was also collected from the all enrolled participants. Here we have placed some photos of which we have used during the study period. And we ensured the clinical management. After enrollment, the study physician ensured the participant with acute watery diarrhea were acutely managed. And if the patient with some or severe dehydration, we referred them to the icddr Dhaka hospital immediately. And we carried out the laboratory assays, which include the microbiological culture. And after incubation, the plates were examined for morphological characteristics of Shigella. The suspicious non-lactose fermenting colonies were subcultured onto 4 different media for serotyping, and the Shigella isolates were confirmed biochemically also. Serotyping done with commercially available antisera. After serotyping, Shigella isolates were undergone to antibiotic susceptibility testing by disk diffusion method. And we also carried out the tag analysis, and we uploaded the tag data to the music database platform for the analysis. And the outcome of my studies were the culture confirmed Shigella cases and the qPCR confirmed Shigella cases. And here is some brief about the analytic approach. The trend of secondary transmission of Shigella among the household contacts explored with the number and percentage by month from April 2023 to January 2024. The relationship between secondary transmission of Shigella and demographic, socioeconomic, and WACh characteristics of the household contacts were assessed by using chi-square test and Fisher-Exit test. According to the kitchen sink regression method, all covariates were included in the multiple regression model. Bivariate and multiple logistic regression model had also been fitted to measure the association of the factors in the household contact for developing Shigella infection. And all tested were two-tailed, where p-value less than 0.05 was considered statistically significant. And this is the consort of the study. we have found 78 index culture confirmed index cases during the study period, and we visited all 78 households and approached 266 household contact. Among them, we excluded 31 participants as they developed acute diarrhea less than or equal to 1 day after the enrollment. And for this reason, we excluded 13 cases and rest 19 were refused. And finally, we can enroll 235 participants. And among them, we found 23 culture confirmed Shigella cases. And in this figure, I placed the month-wise enrollment and isolation of Shigella among the household contacts of the index cases. In the x-axis, I placed the month, and the y-axis, I placed the number of participants that enrolled and that was found as positive. In this figure, we can see that in July, we isolated 8 participants, and in October, we isolated 5 participants. And in November and December, we didn't identify any isolates. Though it is a short period study and there was an enrollment cap in the index cases, so we cannot conclude the seasonality from this study. And as I mentioned earlier, we have enrolled 235 participants and we found 23 Shigella positive cases. The positivity proportion of secondary Shigella was 9.8%. And among them, 1 was symptomatic and 22 were asymptomatic. And in this pie chart, we can see the different serotype of Shigella, and we found 10 Shigella flexneri, 5 Shigella sonni, 4 Shigella body, and 4 Shigella dysentery. Among the Shigella flexneri, we found Shigella flexneri 2A, 1A, and 4A, and 6 was non-typeable. And in this figure, I have shown the antimicrobial susceptibility pattern of isolated Shigella from household contact of the index cases. And the isolated strain showed 100% sensitive to ceftriaxone, 96% to P-bembexilenum, 91% trimethoprim sulfamethoxazole. Also, we found 65% resistant to nalidixic acid, 30% to ampicillin and ciprofloxacin, and 26% to azithromycin. And this is the map of the location of household contact in the EFGH study area. The green circle are based on the number of household member, and the red dot in the circle are the Shigella positive cases. And most of the cases we detected from 5 wards out of the 7 wards of the EFGH Shigella study. And in this, we found 11 isolates that were not matched with the index cases. Based on discussion with all investigators as well as the EFGH coordination team, we have decided to confirm the isolate by retesting of stored strain of the index case and their household contacts. For this, microbiological culture and biochemical as well as anti-sera testing were carried out. And we found this the same result after retesting. But genomic analysis of the strain will be helpful to find out their similarity and dissimilarities. However, due to the fund constraint, we cannot do this right now. And we also do the tag analysis, and tag run and data entry onto the music database system has been completed for 90 out of 200 samples. And Shigella positive in 73 samples. Among them, 71 was Shigella flexneri and 4 was Shigella sonni. And 2 samples had multiple Shigella species, which include Shigella flexneri and Shigella sonni. And these are the pathogens identified from the tag analysis. And the high number of the pathogen include Shigella, LT-tech, ST-tech, Giardia. And among the Shigella flexneri, we found these serotypes. And in this table, we can see the demographic, socio-economic WACh characteristics of the household contact according to the Shigella transmission. In the In this table, in the first two row, I have placed the factors along with the levels, and the next column, I placed the Shigella positive number and the Shigella negative number. In the last column, I placed the p-values. And in this bivariate analysis, we didn't find any significant association based on 5% level of significance between the secondary Shigella transmission and different factors in household contacts, including demographic, socioeconomic, and WACh characteristics. And in this slide, the same distribution of the slide with some other factors. And this table shows the factors associated in household contacts for developing Shigella infections. And in this table, I placed the factors and level in first two columns, and then I placed the crude risk ratio along with their p-value, and the next two columns, I placed the adjusted risk ratio along with their p-values. And in this multivariable regression, we found people with secondary level of education had over 5 times higher risk of secondary Shigella transmission compared to the lower higher educated people population. And also we found the people who did not use the soap after defecation had 7.11 times higher risk of secondary Shigella transmission compared with them who didn't use the soap. And this is the same table, but we didn't found any other factors that are associated with secondary Shigella transmission. And in summary, we found 10% secondary Shigella transmission among the household contacts of the Shigella index cases. And among the positive cases, we found 40% were caregiver of the index cases. We found the susceptibility as follows, which includes ceftriaxone 100%, p-ampicillinum 96%, trimethoprim and sulfamethoxazole 91%. And in the TAC analysis, we found 79% Shigella species. And a higher proportion was found among the people with secondary level of education, and not using soap after defecation was found to be an associated factor with secondary Shigella transmission. Before going to the implication of the study, I would like to underscore some limitations. We were not able to follow the household contacts for a longer period of time. For this, we couldn't generate evidence on how long the household contacts are at risk for shigellosis. And we didn't collect any food or water sample from the household to determine the source of infection. And lastly, the genomic analysis of the Shigella strains have not been carried out to confirm the secondary transmission, and this could be an important item to be pursued later. And implication of the study. This study on secondary Shigella transmission and household level risk factor will help to plan strategies to reduce Shigella transmission in high risk communities. The prompt identification and treatment of individuals infected with Shigella may be crucial in reducing secondary transmission. And policy initiatives should promote the robust surveillance system for monitoring Shigella infections and timely reporting of cases to help identify hotspots, implement control measures promptly, and track the effectiveness of interventions. And finally, I would like to acknowledge Global WACh for this Rising Star program and also the EFGH consortium. And I would like to thank my mentor, Dr. Firdausi Kadri, Farhana Khanum, Dr. Taufiqul, and also my other team member, Ismail, Najmul, Shun, Kudrati Kuda, Mehzabin, Proshanto, Amirul, and all other staff members. And also I'm grateful to Patty, Karke, Stephanie, Sonia, and Hannah for this journey. Thank you all.
So let's swap onto Billy's slides. But as we move to Billy's presentation, we have a few seconds for any clarifying questions. If there are any in the room? Gone. Okay, no clarifying questions in the room. So Billy, you're up next.
Hello, good morning, everyone. Sorry for the waiting time. We were having some technical issues with the connection. So can you please confirm us if you can hear us and see the slides?
Yes, we can hear you. We see the slides. Thank you.
Thanks, Maribel.
Okay, thank you. So this is project varies for healthcare seeking in Peru. This was developed by Maribel Paredes Olórtegui and her team with Asociación Benéfica PRISMA. And in this opportunity, my name is Karin Perez, and I will be helping and presenting this presentation. So a little bit about her previous work and academic history. Her name, again, is Maribel Paredes. She's a biologist by profession and an experienced researcher who has worked in projects funded by John Hopkins Bloomberg School of Public Health for over 20 years. Over this period, she has worked in a remarkably diverse set of projects, ranging from qualitative observational study of BECMED use to a diverse set of studies on entry disease and childhood nutrition. And her main goal has been to lead focus groups, do thousands of ELISAs to determine if wild-caught mosquitoes were infected with malaria, and lead projects including the Malek longitudinal cohort. And about 3 years ago, as a seasoned program manager and field coordinator, she returned to the classroom to obtain a Master in Public Health at the Universidad Nacional de la Amazonía Peruana. And currently, she is in a doctoral program at the School of Public Health, again at the Universidad Nacional de la Amazonía Peruana. About half the year back her career growth and trajectory, the study proposals she has developed to study barriers to seeking care for acute diarrheal illnesses was prompted by her reflective question about why, in a place where diarrhea is so common and services are readily available, mothers do not see constant attention for their children with acute diarrheal disease. So her participation and leadership in this project has given her more dedicated time to write her own project materials and resulting publications, allowing her to build an independent line of research that she conducts with the support of her team. So a little bit about the overview and key findings from the Rising Star project we obtained. About the specific aim one, it was to determine whether discrimination is associated with healthcare utilization for acute diarrheal illness in Peru. And the data obtained was that in the Peru data since December 2020, until December of 2023, we get 16,459 observations. And we use the data from June of 2023 until December of that same year, and we got 4,744 observations. And last but not least, we obtained the Rising Star participant was 2,183 observations. And about all of this data, we get that 67.9% of the participants attending a health facility in the last year. Also that 44.8% had a child under 5 with living in the household. And also 8.3% of child under 5 had diarrhea in the last year. 43.82% of children under 5 with diarrhea participate in the HUSRV, and 12 of the 43 of children self-care. Another of the results was that 35.6% have received services of lower community than other people, and 52.55% people said that people asked if they were not intelligent, and 40.86% people said that people asked if they were dissonant, and 55.02% said that people asked if they were better than them. So our conclusion for the specific aim one was that we have implemented a questionnaire to measure discrimination within the healthcare setting at a population scale. That's why we get this data. And the discrimination in healthcare setting is prevalent. About our limitations with this part of the project was the only 50% of the population and operation participants agreed to participate in rising star section, and that the study is wasn't powered to answer the question. Like, too few children with diarrheal care. In the other hand, we have the specific aim too, that was identify the main structural barriers associated with healthcare utilization for acute diarrheal illness in Peru. And the data we get that between the 5 health centers we have here in the EFGH project, that is San Juan, Progreso, Biomédicas, Santo Tomás, and Modelo. And of these 5 health centers, 7 areas of attention were identified, in which were emergency, obstetrics, vaccination, related vector diseases, general medicine, and pediatrics. And Santo Tomás and San Juan were the only health centers equipped with pediatrics area. About the electricity, it was available in all health centers every day except in Modelo, and water was available in all health centers every day as well. And about the various service at government sites, we got 900 observations. And from this, we get that regarding public service, health centers provided public service for an average of 189 days, while not providing it for an average of 9 days. This is mainly because of the strikes we have in the health facilities. Also, the physicians attended on a majority of days, and the collected data indicates an average of 175. Santo Tomás was the center with the highest percentage days on a strike for a healthcare professional, and also nurses were on a strike of 8.2%, was 16 of the 190 days in Santo Tomás. Obstetricians were on a strike on 6.7% days, again in Santo Tomás, and technicians were on a strike on 3.6% of the days. This is an overview of the perspective of care regarding the acquisition of prescribed medicines in the population. So the patient's perception regarding their experiences of receiving medication when visiting the center in population enumeration survey was that patients feel they can acquire the prescribed medication. And 82% is that they say yes, and 18% was that they were not getting the prescribed medication. So the conclusions for the specific issue was that services are generally available for all health centers, and the barriers to be addressed in a general manner, such as the lack of specialist areas like pediatrics in some health centers, and also in a focused manner per center. And so we have the Modelo center with the most identified barriers. Also, the availability of health professionals varies by health centers and by type of professional. Also, seeing availability is low. Antibiotics are generally available, although there are health centers with increased shortages. And our limitations were that the structures are done once a week only, so the results are expected to represent the entire week. And last but not least, we have our next steps that view the finished project and the results obtained. Our next steps is to consider this information to future proposal of projects development regarding barriers for healthcare seeking in Peru. And that would be all. Thank you. If you have any questions.
Yeah, so my name is Emilio Well. I'm a data manager based at the Kenya Medical Research Institute at the Center for Global Health, and I'm also a PhD student at the University of South Africa, where I'm studying health information systems, and my PhD looks at the prediction of poor diarrheal outcomes using machine learning algorithms, and the outcomes of focus are longer duration diarrhea, linear growth faltering, and inpatient mortality. For my talk today, I'll be taking you through my Rising Star project, which is also part of my PhD work, and it's entitled Derivation and Validation of a Clinical Predictive Model for Longer Duration Diarrhea among Pediatric Patients in Kenya using machine learning algorithms. So as part of this work, I've been mentored with our site PI, Dr. Richard Omore, as well as Dr. Vincent Mzazi, who is my supervisor from UNISA. And I've also benefited from the mentorship of Drs. Kirk and Patty from EFGH coordination at Unidad. So to the background of my study, we know that diarrhea is a global public health problem in children under 5 years. It causes about 1.7 billion episodes and 1.5 million deaths annually. This burden is greatest in sub-Saharan Africa and South Asia. Longer duration diarrhea, defined as an episode lasting 7 or more days, has been shown to have their health outcomes. And these include higher mortality rate, decreased cognitive function, delayed growth, as well as nutritional deficiencies. And despite the current treatment options available, up to 20% of acute diarrhea progress to LDD, and treatment at ensuing visits tend to be more costly and prone to treatment failure. Predictive models can be used for the timely identification of patients at increased risk of LDD, providing the opportunity to administer. Hello? Can you hear me?
Yeah, we can hear you really well, Benny. Keep going.
Okay, so predictive models can be used for the timely identification of patients at increased risk of LDD, providing the opportunity to administer better and timelier care at a comparable cost and with more favorable outcomes. Machine learning has been adopted in public health and clinical practice to rapidly develop data-driven prediction models. And despite the several successes of the application of machine learning to the prediction, the application of machine learning in public health and clinical practice, no predictive model exists in literature for LDD. And accordingly, we seek to use machine learning to develop predictive models for LDD, the aim being early identification and intervention in children at increased risk of LDD in Kenya. I have 2 study objectives. The first was to determine the features or covariates that were associated with LDD, while the second objective was to derive and validate machine learning predictive models for LDD among children aged under 5 years. What is the approach that we had? So our study is a retrospective study that leveraged 2 de-identified diarrheal datasets from the Kenyan site. The first study is the VIDA study, which was used for model development and internal validation. So VIDA was a case control study that was done in 3 African countries to assess the diarrheal etiologies, vaccine effectiveness, and population-based impacts of the introduction of rotavirus vaccine in these settings. And then the second study that we used was the Enterics for Global Health Shigella surveillance study, which Patty introduced during our opening. And EFGH is a longitudinal study that seeks to establish the incidence and the consequences of Shigella medically attended diarrhea among children aged 6 to 35 months in 7 countries across Africa, Asia, and Latin America. So for our study, LDD was defined as a diarrheal episode lasting 7 or more days. And the duration of diarrhea, which was our main outcome, was got from 2 sources. The first is the pre-enrollment duration, which was based on caregiver report, and this could be between 1 to 7 days, while post-enrollment duration was extracted from the memory aid in VIDA and from the diarrhea diary in EFGH. Additionally, for EFGH, for those children who did not have the diarrhea diary returned, we got this information from the week 4 or month 3 follow-up if it was available. During the post-enrollment period, 2 diarrhea-free days were considered end of an episode, consistent with the previous studies. In terms of model development and validation, so this is the approach we took. We started with pre-process coded some of the predictors, as well as assessing the missing data patterns, and we conducted imputation for the missing data points. This was done using the WACh package in R. Thereafter, we conducted feature selection. This was done using, we did feature selection to optimize the accuracy of our models, as well as to reduce the computational cost. We did it using the WACh package, which is a wraparound random forest algorithm that compares the original attribute features to original attribute importance to importance achieved at random using their permuted copies. And from the feature selection process, features that were either confirmed or those that were tentative were used for model development. Thereafter, we conducted split sampling, partitioning our data in the ratio 3:1. 75% of the data was used for training. And to do the training, we used 7 machine learning algorithms, and this was based on diversity by family, as well as prior use in predicting healthcare problems, as well as their popularity and potency. We used the random forest, the gradient boosting, naive Bayes algorithm, logistic regression, support vector machine, the k-nearest neighbors, and the artificial neural networks. And during training, we employed tenfold cross-validation. And because there was a modest class imbalance in our outcome variable, we employed the oversampling technique within the resampling procedure to address that. And once the models were developed, we evaluated them on the test data set that was set aside, and we assessed for various metrics, including sensitivity, specificity, the positive predictive value, the negative predictive value, the F1 score, as well as the area under the curve, and the precision recall AUC as well. For the top 4 models, we conducted exploratory model analysis just to understand how the models, the various algorithms were reaching the decisions they made. And to do that, we used the WACh package to compute sharp attributions to get the dataset level feature importance. Based on the model AUCs, we chose our champion model, being the model that had the highest AUC. And once that was done, we conducted a business value evaluation of that particular model, just to understand how well our model was at identifying LDD cases compared to a random selection, as well as to identify the proportion of LDD in our population that our model is able to identify from the given selection. And finally, we conducted temporal validation to assess the reproducibility and generalizability of our model. In terms of ethical consideration, the VIDA protocol was approved by the IRB at the University of Maryland, as well as the Scientific and Ethics Review Unit at KEMRI. The EFGH protocol was also approved by the Scientific and Ethics Review Unit at KEMRI. And we also sought additional ethical approval from the Health and Research Ethics Committee of the University of South Africa. So to our results, this is a flowchart of the 2 studies. So from the development cohort study, which was VIDA, which was done between 2015 and 2018, 2,895 children presented with diarrhea at our Sentinel Health facility. 69% of those met the VIDA moderate to severe diarrhea criteria, and out of those, 1,554 enrolled. Out of the enrolled children, 95% had their memory aids card completed, and out of those, 178, that is 32%, had LDD, while in our temporal validation cohort, which is the EFGH study, we had a total of 1,879 children presenting with diarrhea at our Sentinel Health facility. 72% of those were eligible for screening, and upon screening, 706 of them, that is 52%, were enrolled in our study, and 97% had a diarrhea diary completed, of whom only 69, that is 10%, had LDD. We see that there was a significant difference in the prevalence of LDD between those 2 studies, with the VIDA having more severe cases based on its definition. This is the output from our feature selection, which we did with Boruta. So the green box plots show features that were selected, while the yellow box plots show features that were tentative, and the red ones show features that were rejected. So from our results, we see that pre-enrollment diarrhea days, severity of disease based on the Vesicari score, the age group, vomit days, breastfeeding, respiratory rate, vomiting, as well as the frequency of vomiting, rotavirus vaccination, as well as rectal screening are confirmed features, while skin target and stool frequency were tentative features. So we use these features in our model development. However, we excluded rectal screening and breastfeeding because they were not collected in EFGH, and we did that so that we could be able to compare the model across the two studies. How did our models perform? So we see the random forest algorithm had the highest sensitivity at 80.7%, while the gradient boosting and the SVM model had the highest specificity at 76.5%, while the AUC, the random forest had the highest AUC with a point estimate of 83.0, as well as a 95% confidence interval of 78.6 to 87.5%. It was consequently chosen as our champion model. And also to report on the explanatory model analysis that we did this for the top 4 models. And this was a random forest, the SVM, the gradient boosting, and the artificial neural networks. We saw a similar pattern across the 4 models. However, the magnitude of the association varied. The green bars show features that had a positive relationship with LDD, while the red bars show features that had a negative association with LDD. And in summary, pre-enrollment days, lack of rotavirus vaccination, severity of disease based on the Vesicari score, as well as age group and respiratory rate are positively associated with LDD, while vomiting and increased stool frequency were negatively associated with LDD. We also conducted business value evaluation for the random forest model, which was our champion model. And if you look at the cumulative gains plot, that is the first chart, we see that if you were to pick the top 20 cases based on model probabilities, then we'll be able to identify 45% of LDD cases in our population. Again, if we look at the cumulative lift plots on the right, we see that if we pick the top 20 cases, then our model is able to identify 2.5 times more LDD cases compared to a random selection. We conducted temporal validation of our champion model, and we observed a decline in model performance with the AUC dropping from 83% to 68.4%. This was largely driven by the drop in model sensitivity, which dropped from 80.7 to 37.7%. This decline in performance could be attributed to the spectral differences in the severity of diarrhea between the two studies, as well as possible shifts in population over the study period. We went further and restricted to EFGH cases that met the VIDA MSD case definition. And when we did that, we saw a slight improvement in model performance with the AUC now reaching 71. But overall, there was still a decline in model performance. To some limitations of our study, despite laboratory results being available, they were not used in model development, despite the evidence that has shown some association between certain enteropathogens and extended duration of diarrhea. However, we did this to preserve the practical utility of the model, as these results would not be routinely available at the point of contact with the clinician, and that is further coupled with inadequate diagnostic capacity at the public facilities in our setting. To the conclusion of my study, we see that our study shows the practical utility of machine learning algorithms in rapid identification of children at increased risk of LDD. The integration of our validated random forest model in clinical decision making could help to prioritize resources at high-risk children, ensuring close monitoring and better management. However, the successful implementation and widespread adoption will require further research, collaboration, and ethical diligence. Our findings also highlight the need for monitoring and periodic retraining of the model in order to maintain its predictive accuracy. So some areas for next steps. One is to integrate this champion model as well as champion models from the linear growth filtering prediction and the mortality model into an online dashboard to allow for prediction of poor diarrheal outcomes. Once that is done, we would also like to assess user acceptance of such a tool in clinical practice, as well as assess the impact of the tool on patient outcomes and clinical practice. I would like to acknowledge the following individuals and organizations without whom this work would not have been possible, and thank you.
Thank you, Billy. So we are very nearly at the top of the hour. So if people need to run off to other meetings and other talks, feel free to. But I think For those of us that can stay, we can go a little bit over time. Any questions for Billy or for any of the panelists? Adi.
A question for Billy. What do you think a clinician would do differently if they knew that, a child that they're seeing has a higher risk of longer duration diarrhea?
Yeah, thanks, Patty, for that question. So maybe to respond is that we know the IMCA guideline on management of diarrhea, and zinc is normally recommended to shorten the duration of diarrhea as well. So in essence, if the model showed that a child was at increased risk of LDD, first, the clinician would have to adhere to that guideline to see that it was achieved, but also they would put the children under close monitoring and maybe ensuring follow-up just to ensure that the diarrheal episodes did not continue.
Taufiqul, I had a question for you. I was really interested in the serotype matching that you're doing for different Shigellas. And it's good to hear that you're planning to retest to see if you get slightly different results. But you obviously had quite a few children with discordant, or quite a few household contacts with discordant Shigella serotypes. And I wondered if that, in addition to the risk factors you found, might be an indication that the two cases share the same exposure, but have not necessarily transmitted Shigella, from the index case to the household contact. If they just both have a water source, or a water source that has, fecal contaminant in it, or perhaps, hygiene practices within the household that are making them vulnerable to infection. So do you think that might be true, or what's your theory behind that?
Okay, thank you, Kirk, for the great question. So I may cannot clarify this in my presentation regarding the serotyping retesting. So we have done the retesting for all the isolates, stored isolates, and we found the same results. This is one thing. And regarding the exposure, yes, you're right. I think all the household is same exposures, and unfortunately, we have not found the covariates significant. And also, we have done these analysis by following the kitchen sink methods, and we used all the covariates in the model, and we found two variably associated. But in that two variable, there is chance of multicollinearity. So I'm not so sure. This is just preliminary analysis. I'm not so sure that two variable is also a strict predictor for this transmission. So I think it should be more explored.
Yeah, thank you. It's really interesting that you got and reassuring that you got exactly the same result the second time around. Any final questions? I don't know if the participants online can post in the chat. They can. If you want to post questions in the chat, please feel free to do that as well. I had one final question for the team in Peru. I hope you're able to hear okay. I wondered if you're able to offer any insights as to why the participation rate in your additional questions that you were asking was low. I think you said only 50% of people consented to be part of the Rising Star questionnaire. Do you have any insights as to why that was? A bit concerned you can't really hear us. so I can follow up with you via email. Any final questions?
Yeah, sure. I hear your question about why we have 50% of the participants answering the survey of the Rising Star project. And looking at the data analysis we did and the field work we watched during the development of this project, we determined that the main factor was time, because our survey was done after the household, the cluster survey that was on service deal. So people were kind of tired of this process, and then having another person doing this questionnaire, it was like a lot of time for the household caregivers. So one of the factors was time, was the main principal factor was time.
Yeah, that makes a lot of sense. I was wondering that. Okay, well, thank you all for taking the time to join us today at really weird hours of the afternoon and evening and night and morning. And thank you for all of the people who joined online and everybody in the room. It was really wonderful to hear about your projects, and looking forward to reading your papers too. Thank you, everyone.
Thank you.